The next on my list is Barbara Doty. Barbara Doty is a medical doctor and a primary care family physician in Alaska. She has done work in curriculum development for family physicians, including starting the first family medicine residency program for Alaska, focused on training for rural and remote practice. She continues to practice, including obstetrics, difficult words. And also she is active with the World Organization of Family Physicians and the American Academy of Family Physicians as well. Barbara will be talking about the role of family physicians as leader in community preparation for climate change effects. This will be based upon implementing the Center for Disease Control BRACE framework. Please welcome Barbara.
Again, thank you for the organizers for the privilege of being here. I'm going to take the systems and bring it down to the delivery system and particularly the workforce. I practice in a place where there's rural, remote, Arctic practices, and we were challenged by how do you train physicians for rural and remote practice. And I have colleagues from around the world, especially Canada, Australia, and South Africa that have tried to address this issue. And what I was interested in is how do you actually train them to identify what their role is with climate change, especially in the Arctic where it is so palpable. My first picture here is a picture of my colleague who is a fisherman out in Western Alaska, and they have definitely seen climate change issues. His fiance is the physician in Unalaska and has been involved in how do we communicate climate change in our community, and how do we identify what the health risks are, and how do we address that as clinicians. After looking at this together, we both decided that the best way to approach this as a clinician is that the community is a patient. We speak and think as family physicians, as community members, all the time assessing someone as a patient. And so in this case, it's easy for us to transfer that as clinicians to thinking about it as the community as being the patient. So what does that mean? That means that our role as leaders, as community-based, team-based individuals that provide health services for the community, and truly this is not just for physicians, it's for the public health nurse, it's for the entire team that does healthcare delivery in the Arctic. How do we look at our role as providers of healthcare, and how does climate change and preparation for climate change work in that setting? So what do? We do an assessment. We do a needs assessment. We determine what the vital signs are of our community. What are our health risks? Are we in a community where melting ice and changing salinity of the ocean is threatening, or where the change in climate will change the type of infectious disease vectors that may come to our community? So how do we do a health risk vulnerability? Is a tsunami coming in as a result of a storm or a volcanic activity, is that a risk for our community as the climate becomes more volatile and changes? The Center for Disease Control of the CDC seemed to be the best resource I could find as a framework in which to have a community come together to address the health and well-being of their community in the face of climate change. They have put together a context called the BRACE approach. It's a framework which is building resilience in your community against climate change effects. And it specifically looked at how do you develop a healthcare approach to this and identify what the risks are and then attempt to mitigate that. So I took this BRACE technique and have started to talk to my colleagues as physicians and clinicians in the Arctic and in rural remote settings and ask the question, what do you do if you're preparing your community? And how do you look at that? And how do you do an assessment of the vulnerability of your community? And I often will refer them to this fairly well-structured system to say, I'm going to do a vulnerability assessment. I'm going to find out who the most vulnerable population is in my community because I work in my community and I know my community. I'm going to identify what my health workforce population is, and we're going to start looking at what the climate change effects might be and how we could mitigate that. In order to do that, you have to project the disease burden. And disease burden is a medical term in the sense that we're looking at disease, but in fact, we're looking at the whole person. We're talking about mental health and well-being. We're talking about social and economic health and well-being as determinants of health. And we're looking at the health status of the individuals as well. And we're asking ourselves, what are the populations at most risk? Maybe it's our maternity population, our pregnant women or our children. Maybe it's our elderly population. And each community is different, but doing an assessment of that community's health and well-being status and their vulnerabilities allows you to look as a health clinician at the population and say, okay, here's what we can do to help mitigate the effects of climate change in our community based on our current environment and population. So you have to anticipate what those climate changes are. And it might be that you live in Toronto, but your community has engaged in a mitigation plan for the onset of malaria carried by mosquitoes that are coming north with warmer climate. It may be related to a change in food availability or transportation availability in the remote Arctic areas. I know in my communities that are further north and much more remote and only accessible by plane, that those transportation systems are vital to the well-being of the community, and perhaps we have to look at food security from a transportation point of view in order to look at the health and well-being of the community. And not just whether the fish stocks are good, but actually what if we got cut off by the air or by the transportation system that's most frequently utilized. There are public health interventions that we all know, but we don't always teach these in our academic settings or in our physician or medical professional training programs. And one of the reasons why I have been impassioned about this topic is because I think that we've taken, at least in the United States, the public health piece out of a lot of our medical education and separated it. And I think it's time that, especially with our primary care clinicians, that we make sure that we have good fundamental public health training and the ability to look at a community and identify emergency response team capacity, to look at infectious disease mitigation, lots of things that we aren't necessarily good at doing as team community-based clinicians because we haven't had the training. So it's one of my passions is to be able to include that type of training. We need to develop a plan, and that often takes public input. And we have to have a method as a community to come together in a public forum and say, I have these concerns. This is what my health concern is. Make sure that we have good needs assessment data for our communities that is documented in a place that we can access, that we can follow over time. We need to be able to have it based on local capacity. So, Alaska statistics are Arctic statistics. They're much different than other places in the United States. So we need to be able to have a local assessment, or at least a regional assessment that can be applied to our community and translated to the workforce that's providing the healthcare delivery. We also have to evaluate the impact of our plan. So if you make a health needs assessment and you find a plan that you want to implement for the health and well-being of the community, and it's led by the community with clinician input, then we have to actually make sure we write it down, that we can evaluate it over time and revisit it. It shouldn't be on the shelf. It should be a living document that we visit as part of our regular routine. Just like we practice our disaster drills to be able to respond to an emergency, we also need to respond to our plan and be able to look at that and respond to it and correct it and improve on it. Most of the Arctic is rural. So what does it mean in a rural setting when we look at a health plan to mitigate the effects of climate change? Part of what it means is that you have to look at what your rural and remote setting is. But we've also got indigenous populations that have a great deal of knowledge and expertise in surviving situations that may have been in other environmental settings a disaster. The fortitude, the willingness to move forward as a group and pull together is felt in small communities and Arctic communities, I think, greater than any other place in the world. I experienced this year when we had both in the same community a large wildfire, followed by a month later a large flood. That community pulled together and pulled their resources together, housed the people that were displaced, identified ways to rebuild their homes, and then turned right around and did that again. And that's what I call community action, led by the community, but integrated with that is the healthcare delivery. This is a group of people, family physicians across the country that have been involved in looking at health and well-being and developing training programs. And I have a great deal of respect for the effort of pulling people together. There's hope for the future, and I look forward to partnering with other countries to be able to do this. Thank you.